medicine at UPMC. I'll just also say that I heard like during the VMRs that a lot of people here are applying this year. So I'm always happy to chat about interview process whenever. So just gonna put this out there. Yeah, and I'm interested in rheumatology in terms of, future.
Amazing. Well, thank you for joining us. Tell this crowd a little bit about you outside of medicine. I think it's the first time that they're meeting.
Outside of medicine, I'm from Brazil, so I'm a big barbecuer. I love cooking, and I love traveling too, and I'm a little bit outdoorsy. So
I'm surprised Professor didn't unmute because he is a barbecue king. He actually made me delightful barbecue.
I feel bad. You didn't experience my best type of burger, Robbie. Next time.
Okay. There's always next time.
Next time.
I'm good at eating, but not making the barbecue.
All right, well, take it away, my friend.
Okay, so the case I have today, I saw during intern year. It's a 65-year-old gentleman coming in for right leg swelling and pain. So he comes to us in the medicine service telling us that out of the blue, 2 days before he woke up, he saw his leg was very swollen and very painful, and the skin looked weird. Without any trauma before, he really couldn't explain why that happened. But he got concerned, his wife got concerned because his leg was so big that he thought he should go to the ED. He mentioned, do I continue?
No, maybe we can raise it. Maybe we can pause. And how do you pronounce your first name?
The R sounds like an H.
Okay.
And it's a 3-syllable word, so it's Haiza. It's a little tricky.
I wanted to call you Reza because I love that name. Oh, we won't do that. Haiza. Haiza, I have to say one thing. I agree completely with Mukan. Sorry, Mukan, if I'm mispronouncing your name, but this is gout until proven otherwise. I'm just joking. All right, let's approach this problem. Well, the problem we're dealing with is really interesting. Actually, Haiza has painted the entire PR for us, meaning the age of the patient, the sex of the patient, the tempo of disease, and the clinical syndrome. So this is an elderly man presenting with sudden onset left leg swelling. That's atraumatic left leg swelling. That's your PR. And right away, I think it was right leg. Is that right? Right leg swelling.
Yeah.
Right away, this is so important, the difference between right and left. Why is that? Because the right iliac artery in all of us courses over the left iliac vein. So in all causes of edematous states, the left side's a little more swollen than the right side. But if you're able to notice this difference in swelling, even if it's on the left side, don't say Reza said don't get an ultrasound. You should get an ultrasound and rule out a clot. But just know that this is the normal anatomy of the human body. And the reason that that's relevant here is because we're dealing with right-sided swelling, which is way more concerning than left-sided swelling where you can't exclude total volume overload states. So with right-sided unilateral swelling that's sudden onset, like DVT is my reflexive thought. That's like S1 thinking. But then if you took more of like an analytical approach, you can just put an arrow going through the leg, starting at the level of the skin. So could the patient have a cellulitis? Go a little deeper. Could it be a deeper infection like necrotizing fasciitis? Go deeper. Could it be something going on with the bone that's now showing itself on the surface? Don't forget the vessels. We already talked about a venous clot. And don't forget the joints when you're evaluating this patient. That's all I have to say about this, but acute right lower extremity swelling, the top diagnosis to consider is a clot and infection, but you can't exclude other anatomical spaces until we get more relevant data. Robbie, anything to add before we move on?
Yeah, maybe I'll just summarize. So when you're in this situation, remember, Reza said, don't get an ultrasound. Okay, I'm kidding. Please get an ultrasound. All right, Lisa, back to you.
Um, so I see some questions on the chat. So the leg itself was very sudden. He woke up, he looked at his leg, he was like, wow, this is painful. This is weird. But when we ask him a little more questions, so over the past 6 months or so, he had been having decreased appetite. He lost some weight, like generalized fatigue. And he said maybe some chills at night.
Lisa, I think maybe I can just comment real quick on the data you just provided and pass the mic to you to tell us more. I think that it's not surprising that there's background data for this case, because most healthy people don't just wake up with severe sudden swelling of their leg. Most people who have a DVT have a risk factor for DVT that's in the background. And most people who have cellulitis have a risk factor for the cellulitis to show up. So, normal walkie-talkie people just don't get a DVT or cellulitis, the two most likely considerations here. And the question is, what do we do with the information you provided? And I think it doesn't move the diagnostic needle much, except reinforce this notion, because you could say that this is a cancer, and the background symptoms are cancer, and this is a DVT. But you could also have the same argument for cancer and then say immunodeficiency, hypogammaglobulinemia, and cellulitis. So I think now you're a little bit less surprised, honestly, that somebody just woke up with sudden onset pain and have a much more much more cohesive story to explain. And I would separate them. I'd be like, what is the background symptoms? Those are a very different diagnostic exercise. It will be influenced by what you find as the cause of the current acute symptoms, because if you find a DVT, you're going to be running towards cancer. If you find a cellulitis, it's still a consideration, but maybe a less prominent one.
So yeah, Yasmin, you wrote fatigue, chill, so weight loss and decreased appetite, kind of, not feeling great in general. In terms of symptoms, that was mostly what he had. Can I continue to like past medical and stuff? Okay. Past medical, he was diagnosed with rheumatoid arthritis like 20 years or so back. Not on any treatment currently. He had mitral valve prolapse and hyperlipidemia. Surgery, just like appendectomy. Family history, his dad has bladder cancer, but that was basically it. Social, he was a former smoker, fatty. He had 40 packs a year history, quit a few years back. He was a former drinker, heavy drinker, also quit a few years ago. And he loved to do Krav Maga and Jiu-Jitsu, like a lot of like fighting hobbies, and he was retired. He was not, let me know if you need to repeat, because I think I just dumped a lot of info, but he was not on any meds. He was not a big medicine taker, and no allergies. Do I go on to physical? Okay, let's go. When he came to us, let me get his vitals. His temperature was 37, blood pressure was 90/60, pulse was 95, respiratory rate was normal. He was setting 97 room air. And on physical exam, I have a picture of his leg. But other than the leg, general, he looked okay. HENT was normal. Cardiovascular was normal, just, borderline tachycardia. Pulmonary also was normal. Abdomen neural was normal. Musculoskeletal, he had contractures of his elbows bilaterally, so he couldn't extend both elbows. And then the leg that I have a picture, I can show you guys. Let me share my screen. Can I share my screen?
Yep, you should be able to. Let me know if you can.
I think I can. Let me see. Can you guys see it?
It's coming. Yeah, there you go. Wow. Oh.
Can you just keep this up and we can like talk about it?
Okay.
Isa, is that okay?
Yeah,
So
absolutely.
maybe what I'll do is I'll start talking about it, and then I definitely would love Robbie's input on this. Heidi, can you put it? Yeah, thank you. Okay, so folks, when you look at this rash, you can already define it as purpuric in nature, right? Like there's no doubt that that is a non-blanching purpuric rash. So already you can translate that in your mind to extravasation of red blood cells. So red blood cells have left the vessel. I do have to mention something, and Robbie sees this way more. I guess I see it now too, but he probably sees this in the ED. When I see ecchymoses in the popliteal region, reflexively, I think of a ruptured Baker cyst. But this is extending way above the knee and below the knee. And Heiza, is it also on the anterior surface or only the posterior surface?
The anterior too. It
Anterior.
looks similar.
Okay. So then the next step that will be really helpful here is a couple. One is you want to know what are the platelet counts, what are the INR and the PTT. You have to just think about anytime you see, basically this patient is bleeding in their skin. So I'm activating the schema for bleeding. And in that schema is going to be PT, PTT, and platelet. But it would be really weird for bleeding to just happen in the right leg. That's odd. This is like focal right leg atraumatic. So now we have to think about some form of vessel injury. And here you can divide it into like a vasculopathy or vasculitis. By the way, it could be that the patient is vulnerable to bruising and doesn't remember trauma or something that happened, but I think it's just odd that it's posterior and anterior. So the next step in the physical exam is closing your eyes, wearing gloves, and seeing if this is palpable or not. Because if it's palpable, then you can think about vasculitis. That's palpable purpura, thinking about leukocytoclastic vasculitis. If it's non-palpable, it still doesn't rule out the possibility of vessel inflammation. And why don't I actually pause there and pass the mic to Robbie so you can get both of our inputs, but I'll summarize from like where my mind is right now. This really looks purpuric. It's localized. I want to know how well is the patient able to clot? And I also want to know, is there vessel damage? Then I would layer on the background data to make even more progress.
Yeah, Professor, I couldn't agree more with you. And I think that I think in parallel with trying to figure out the cause, you have to worry about the consequences. And unrelenting bleeding like this makes you concerned. The patient is certainly at risk for developing compartment syndrome. So that would be something to be key. And I would recommend that they stand like this for a picture and then lie back down and elevate their leg right away, because the risk of collecting that blood in that extremity is high. And I don't have anything to add to the superb diagnostic analysis, but just a practical point, which is the most, like Reza said, your bleeding activates what's the platelet count and what are the coagulation, right? And the key question is, what are the most common causes of those things? And for somebody to have ecchymoses from thrombocytopenia is rare. It's more likely that the patient has a coagulopathy if one of those two things is abnormal. And the question is, who gets a coagulopathy? It's patients with liver disease, it's patients with DIC, and patients on medications. And there's no reason for us thus far to suspect these things. He's not on an anticoagulant. He doesn't have signs of cirrhosis, and there's no overt reason for him to have DIC. And so I think you're gonna have to get super precise data. So this is the time when you're asking your colleagues to draw up the blood work to make sure they don't use the heparin tubes. Because I can't tell you the number of times I've had a misleading PTT because there's simply heparin in the line or heparin in the tube. Like this is a very, very concerning situation. So practically speaking, keep an eye out for compartment syndrome, and don't lose an hour waiting for the labs by getting the wrong ones with heparin in them. This is the time where you ask everybody, please make sure there's no heparin in these tubes and collect the data. Because I think you're anticipating a significant coagulopathy. You're anticipating it. You don't want to anchor on it, but you should definitely anticipate it.
Robbie, question for you. Does the fact that it's just like in one extreme, because remember that case we had at Northwestern, which was like gross refractory hematuria, and it was the only manifestation of the patient's prolonged PTT
Yeah.
from a factor deficiency. Can we ever make any more progress on like it just being in one place? Like, is there any way to explain it from like a pathophysiologic perspective in the
Yeah.
setting of a clotting factor deficiency?
Not that I know of, honestly. And I would be like right now when you're just meeting somebody, there's an ER principle that Mike Najat teaches me, which is if somebody comes in on day one with something, you don't know what day 7 or day 8 is going to look like. So if this was day 15 of this and it was only in his right leg, then I would scrutinize that analysis closely and make sure I answer it. But on day 1, we don't know if day 2 his left leg's going to be involved, and day 3, so I don't know.
It's
I
like
don't.
your patient with ataxia, which was unilateral.
Yes.
Then it ended up becoming bilateral because it was the big. I love that. Okay, great. Thank you.
Yeah.
Okay.
All right. So tell us more, please.
Let me give you some labs. So on admission, his white blood count was 12. His hemoglobin was 6.6. Platelets were 300. His BMP was unremarkable. Oh, thank you. Just 1 second, I kind of lost my. Yeah, his BMP was unremarkable. His coags has INR 1.3, PTT 98, and calcium mag. Everything else was pretty unremarkable. And CPK was normal. EST-LT also within normal limits. And you guys want imaging? Or do we stop there?
Yeah, I think maybe I think in real life it probably evolved where you got this data and then got imaging. It's hard to imagine unless like you anticipated something. So I think authentically analyze this data. And I have to tell you, this is the kind of time where you're like in awe of medicine, because this person was fine yesterday, apparently woke up and has this. And I will tell you that there is a over 90% chance that you just made a life-threatening diagnosis. And the good news is that you probably can actually do good by the patient. Yes, all Reza. And all I will say is, and I'd love to hear Prof. Rez digest this. All I will say is, this is a very unique situation because you see a severely discordant PTT and a normal INR. And whenever you see this, it's either accidental exposure to heparin, which we cautioned about, said make sure that this doesn't happen, or the patient has some life-threatening diagnosis or limb-threatening diagnosis. So I'm really grateful that Aisa is presenting this case, because everyone here, if you don't recognize this pattern already, by the end of today, you'll recognize it. And I promise you, you'll never forget it. It's a crucial analysis. So I'm setting up Prof. Rest to fall flat on his face. Take it away.
That was incredible. And I do want to mention one thing before digesting the PTT, is this problem representation has shifted. It's really like, in the essence, it's like what's causing a prolonged PTT. But before even the PTT came back, based on the physical exam, the problem representation was what's causing bleeding, because we identified the bruising, and that's bleeding into the skin. So you see how much progress you can make even before Heisa collected the labs. You were solving the right problem. What's causing bleeding? And we're at the 2 branch points. I do want to say one thing, that the anemia is a consequence of the bleeding. So we don't have to really worry about the anemia per se. We're focused on the PTT. I'm going to teach you a method to like really remember the clotting cascade so that you never forget. When PT and PTT are both involved, this is the common pathway. And Robbie, what's 10 divided by 5?
2.
10, 5, 2. These factors, if they're involved, will affect both PT and PTT. 10 divided by 5 equals 2. The one factor that is solo and doesn't have any friends is the lucky number 7, factor 7. And that only results in a prolonged PT. So factor 7 prolonged PT, 10, 5, 2 is going to be PT, PTT. And we know that medications, liver disease, DIC can do 10, 5, 2 indiscriminately. And then all the other factors are going to be your PTT. This is 8, 9, 11. And out of nowhere, one diagnosis you can't miss, which is antiphospholipid syndrome. Antiphospholipid syndrome, which is more of a clotting problem despite the prolonged PTT. The prolonged PTT is because of the interference of the phospholipids with the assay. So here you're like 8, 9, 11. 8 and 9 are your hemophilia A and B, but I'm going to just share a general principle with you that we know one of these factors are deficient, okay? 8, 9, 11. The question becomes, is the factor deficient because the patient has a factor deficiency, or do they have an inhibitor on board? Is that clear to people? Give me a few head nods if that makes sense. Either they're deficient in the factor or there's an inhibitor that's consuming the factor. Now, the exercise I want to give the audience is maybe take 20 seconds. How would you determine, do this in your mind, don't look at the chat for a second and then you can contribute to the chat. How would you determine whether you're dealing with the deficiency of a factor versus an inhibitor of a factor? Excellent. Excellent. That Lee, you're absolutely right. A mixing study. You can't just measure the factor because it's going to be low in both circumstances, whether you have deficiency or an inhibitor. So you're going to do a mixing study. If the mixing study corrects, is it a factor deficiency or is it an inhibitor? It's a deficiency, right? Because you're literally giving the factors that the patient is missing. So the next steps in this patient is going to be doing a mixing study to see if the PTT corrects. If it corrects, it's a deficiency. If it doesn't, it's an inhibitor. But we have to actually measure these factor levels, 8, 9, and 11. And then we have to ask the question, is this, if it's an inhibitor, it's acquired, what's driving this process? What's driving this process? And I'm going to actually pass the mic. Well, let's get the preliminary data, and then maybe Robbie can analyze the acquired versus inherited. But that's the broad overview. Heiza, maybe you can give us the mixing study, the factor levels, and then pause, and then Robbie can analyze. If that seems reasonable. If not, do whatever you had planned.
Yeah, I'll give you guys also the imaging because I thought it was interesting. He came to us with an MRI of the leg, basically showing, I won't do the whole read, but basically showing a myonecrosis. And he also came with a CT of the leg that showed a large hematoma. So imagings were discordant there. And mixing study did not correct. And factor 8 was undetectable. So those are kind of.
Lisa, absolutely fascinating. I think that if you're trying to go with the CT versus MRI, remind yourself when people are found down, they have rhabdo. And if you image them, you would see myonecrosis. Now, what does that have to do with anything that you're seeing here? Is remember, large hematoma compresses and causes compartment syndrome. And compartment syndrome is pressure-induced necrosis, right? So what you're literally seeing is the consequences of a hematoma on the muscle causing it to die. So this situation is basically the equivalent of localized compartment syndrome, which I think you have to be very worried about. Now, let me tell you how you could have predicted this result, that this is an acquired inhibitor and it's factor 8. So remember that Reza told us that we're in the PTT pathway, so it's either factor 8, 9, 11, or phospholipids. And you have a patient who has no previous coagulopathy, who develops an abrupt coagulopathy without medications. So it's almost certainly an inhibitor in this situation. The other reason to suspect an inhibitor is the patient has an autoimmune disease. And about 50% of patients with autoimmune disease about 50% of patients with inhibitors have underlying autoimmune disease, like lupus and RA. So the setup is there. But how could you have predicted factor 8? And this is the fun pathophysiological pearl. So factor 9, factor 11, and phospholipids are all made elsewhere. What factor 8 is made in the blood. It's made in endothelium. Now, it's great to be made in the blood because you could jump in and do your work right then and there. But the problem is you're constantly exposed as a target for autoimmune attack. So endovascular antigens like von Willebrand's factor causing TTP are constantly exposed. So by far and away, the most common cause of an acquired factor is acquired factor 8. It's not even close to factor 9 and factor 11. So how do we know? How could we have suspected it's acquired? It's new and the patient has an autoimmune disease. How could we have selected between 8, 9, and 11? 8 is endovascular. It's bound to von Willebrand's factor as a reminder that it's made in the blood vessels. And as a result of its endovascular location is much more commonly attacked by autoantibodies. So now I think you have diagnosed a factor deficiency and the Mixon study didn't correct. So you know you have an acquired factor 8 inhibitor. And before you assume it's from the RA, you should probably look into the possibility that RA has transformed into a more aggressive version or transformed into a cancer like lymphoma. But that doesn't matter. Right now, you need to stop this person from bleeding down to a hemoglobin of 6. So this person needs whopping doses of factor, immunosuppression to suspend factor activity, and a workup to make sure that it's not an RA related complication like lymphoma. So there's a lot to do for this patient, but acutely you want to stop their bleeding. Prof, has any other thoughts?
No, I love the pathophysiology, Robbie. The concern for compartment syndrome and whether this patient needs alleviation given the underlying myonecrosis. As an ED provider, I mean, like for me, I would consult my colleagues to help assess that. But to me right now, the tissue is dying because of rise in pressure. So thinking about, saving this patient's limb, but then knowing that the patient's also at risk of bleeding if you make like an incision and a fasciotomy. Any thoughts on that, Robbie, before Haida teaches us?
I am so glad that people choose to go into general surgery and orthopedics. Yeah, I don't know. I would call them for sure. And I think it just goes to show you that compartment syndrome is so subtle that very reasonable, outstanding people sent this person for a 30-minute to 45-minute hour-long MRI, and there was still a necrosis on that. So if you think of compartment syndrome, you should call, because relying on the 5 Ps that we've been taught means you're waiting too late. So for me, this case reinforces the notion that we should call.
I love it. So give the factors, try to thicken the blood as quick as possible while you're making that call to make that incision to potentially save the patient's limb.
You got 2 hands for a reason, one for ortho, one for pharmacy. All right, so back to you.
Yeah, so I'm very, how you guys were spot on since the beginning. Like with this case, we were concerned with compartment syndrome when he came to us. So we were doing like Q4-hour checks. He got bunch of transfusions. Robbie already got every point, but for acquired hemophilia, we did factor 7A, like bypassing the cascade for him. We did steroids and cyclophosphamide. It's kind of the main, and it was like hematology and rheumatology were together with us to do the plan of treatment. We did a workup for malignancy, like grossly in the hospital, that was pretty much negative in. So this was thought to be acquired hemophilia A secondary to untreated RA. So I think a couple interesting points, and I'm biased here, I love them, but RA, so in his case, I didn't bring this point, but he was seropositive, like very high titers of anti-CCP and RF. And he had been a smoker before, and he's male patient. So all these factors kind of put him on a higher risk for extraarticular manifestations of RA, like, lung involvement, like acquired hemophilia, all these other complications. And he, on top of everything, he wasn't getting treatment for more than 10 years. So he had like chronic changes like the elbows, contractures, and all of that. And another thing that we also thought it was interesting that he mentioned those 6 months of kind of like these symptoms kind of picture, like weight loss and fatigue and all that. And Room thought that was all from the RA, not being treated. So if anyone has any questions, but to me, that was one of the most interesting cases from residency so far. But you guys solved it very quickly.
Oh my gosh. I mean, that sounds, this is so rare and so cool. And I think clearly you just alluded to the fact this is one of your most interesting cases from residency. So I'm assuming that it's not happening right now, and your ability to recall it and put the story together is a testament to the clinical reasoner that you are becoming and have become, truly. Thank you so much for putting it together. And yeah, I think you can go through the whole journey of the coagulation cascade in this case and learn a lot from it, and also learn some surgical kind of stuff, which we don't often get to do on VMR. So really, really thank you, and really, really appreciate your time. Prof. Rez, thoughts?
I also want to thank you, Heiza. Expertly presented and just such a rich case. And it just tells you to keep asking why and the power of the frame. Like, of course, we're all nervous about rash, but thinking about, like, if you convert in your mind that physical exam to just purpura, then you convert purpura to bleeding in the skin, then you're now solving the problem of bleeding. And then you say, is it PT, PTT, or platelet, or the vessel? Already you made so much progress. And I think what really stands out to me from a diagnostic perspective is even once you have the PTT, like what Robbie taught us, with factor VIII being the most vulnerable factor to inhibition. So using the patient's age, saying this is not deficiency, not congenital, it's likely an inhibitor. And of all the factors, 8, 9, or 11, it's probably 8 if you're a betting person. But then asking why is the inhibitor present? But sometimes it doesn't matter why. You start treatment with immunosuppression, trying to fix the clotting defect. So for those reasons, I thought, and by the way, I think the patient actually had sudden onset pain because of the myonecrosis. Like, that's basically a heart attack of the leg is what this patient had, sudden onset. So the patient was true, despite the disease existing in that background for some time. So a beautiful job, Heiza. Robbie, always enjoy listening to you teach. And we have Madalena on for the teaching points.
Awesome. Wow. I'm really blown away. Heiza, that was really a phenomenal case and just so many teaching points. I was bummed because the internet kind of went out in the middle, so I hope I didn't miss too much. But I will jump into some of the teaching parts. I'm actually going to start with some pre-case pearls that we got because they're just too good to not talk about. So in the pre-case, we talked about how crystals and infection in a joint can coexist. So as an example, patients with gout are at higher risk for septic arthritis. And Reza made a really amazing analogy with, if you think of endocarditis, and those with a damaged valve are at higher risk. And when you're thinking of a monoarticular arthritis, you can think of the same approach that we use for lung consolidation. So is the arthritis due to white blood cells, like a septic arthritis, crystals, water, like trauma, or red blood cells, hemorrhagic? And then jumping into this case, so we had this chief concern of right leg swelling, and we discussed some really important anatomy to consider with right leg swelling, and that is that the right iliac artery courses over the left iliac vein. So when you're in a state with edema, the left leg is usually more swollen than the right. And you can think of an initial differential diagnosis of clot, infection, or DVT. And then when Heiza showed us that really striking image, we were able to convert that image into a non-blanching purpuric rash. And with purpura, you can translate that into extravasation of red blood cells, so bleeding in the skin. And if the ecchymosis is kind of limited to the popliteal region, you consider a Baker cyst, but in this case, it was more diffuse. So we activated our schema for bleeding. And the next step for that is you want platelets, INR, and PTT. And when you think of, who gets coagulopathy, you can think of individuals with liver disease, DIC, medications. Robbie talked about some really important just practical approaches. So for this patient with such a striking rash, we needed to really keep an eye out for compartment syndrome, which is pressure-induced necrosis, and to make sure that there's no heparin in the tubes, which could alter the PT and PTT measurements. So going into, we had just a really phenomenal discussion about PT and PTT. So if we just kind of talk about for bleeding, if both PT and PTT are involved, that indicates an issue with the common pathway, which is 10, 5, and 2. If it's just prolonged PT, you just want to think of factor 7. And then if it's prolonged PTT, you want to think of all the other factors. So factor 8, 9, 11, and then also phospholipid syndrome. And then we jumped into a really helpful discussion for me about discussing factor deficiency versus inhibitors. And the main way you can determine if it's a factor deficiency or an inhibitor is with a mixing study. So if the mixing study corrects, that indicates that it's a factor deficiency, versus the mixing study does not correct, then it's an indicator of an inhibitor. And Robbie walked us through a really helpful way to think about when to suspect an inhibitor. And the two things that should make you suspect an inhibitor are kind of this new onset and a history of autoimmune disease like lupus or RA. And we also learned this really fascinating pathophysiology about the reason why factor 8 is the most vulnerable factor to inhibition. So the other factors 9, 11, and the phospholipid are made elsewhere, but factor 8 is actually made in the endothelium in the blood. So it has constant exposure to autoimmune attacks in an individual with underlying autoimmune disease. So many teaching points, and I learned so much from this. And thank you, Haiza, for presenting, and Robbie and Reza, as always, for amazing discussion.
Can we get a round of applause for Madalena? Like seriously, that teaching, it doesn't get better than what she just did. Like the pace of it, the emphasis on words, and the clarity of thinking, just majestic. Well done, Madalena.
Thank you. Thank you for your teaching.